Research studies and guidelines by experts have advised strategic use of wound-based biopsies in chronic non-healing wounds as the preferred method to find organisms that underlie the non-healing wound and to apply targeted therapies. Let's look at the evidence. It was previously thought that biopsies may be too invasive and traumatic and would not serve as the standard for wound sampling. Swab techniques that obtain only fluid from wounds were devised as a gentler alternative, but with some drawbacks. In contrast, the Kylon fabric tangential biopsy method is standardized so that every wound base will be biopsied in the identical manner. It was previously thought that biopsies may be too invasive and traumatic and would not serve as the standard for wound sampling. Based on the peer-reviewed evidence, most studies conclude that tissue, if available, is the optimal specimen for planktonic and biofilm non-planktonic organism identification and information regarding antibiotic sensitivity. So let's look at this in more detail. Why move to PCR testing for wounds? The progression to PCR analysis over wound culture is highlighted in this first study by Melendez and colleagues out of Johns Hopkins in 2010. They found that real-time PCR was attractive over historical use of culture because the results on organisms returned rapidly. The researchers preferred tissue samples in evaluating the 29 chronic wounds in this study. This Practice Point article from 2004 is based on references from two peer-reviewed research studies by Robeson and Stotts. It concluded that the gold standard in organism identification with culture should be tissue biopsy, and that it is key that the wound should be debrided of slough and necrotic debris prior to sampling the wound base. In this study by Armand and colleagues from 2013, they conclude that if a swab was to be used, the Levine method of inserting the swab under the wound bed surface and wiping in a Z direction was the gentler alternative. However, they also conclude that quantitative culturing of wounds with tissue biopsy is the criterion standard. The European Society of Clinical Microbiology and Infectious Disease, the ESCMID, published a guideline on best practice for the diagnosis and treatment of biofilm infections in 2014. The ESCMID concluded that biopsy tissues are the most reliable samples to reveal biofilm and that swabs are inadequate due to contamination from the skin flora. More reliably, biopsy can excavate and retrieve biofilm and anaerobes that reside more deeply in tissues. Dr. Gregory Schultz and other experts from the Wound Healing Society published a review of their consensus opinion on identifying organisms in biofilm in 2017. They teach it is imperative to identify biofilm in chronic wounds, not just the planktonic organisms, if treatment is to be effective. Otherwise, if biofilm remains present, there's a potential for persistent or recurrent infection. It's ironic that prior to this introduction of soft biopsy for wound sampling, this consensus by experts concluded that a single punch biopsy may not be sufficient in identifying the full scope of biofilm due to its heterogeneous distribution across the wound, but that multiple punches, or more strategically tangential biopsies or curettage, should be the gold standard in identifying pathogens in biofilm infection. Last, this study by Penuncialman and colleagues from 2010 reassures clinicians that wound biopsy does not delay the healing of a wound.